and dear postgraduates, good afternoon to one and all. On behalf of the Department of Obstetrics and Gynecology, Adupadai Medical College, and as the organizing chairperson of Ignite 2022, I am privileged to deliver the welcome address. With the divine blessings of our founder chairman, Dr. Shanmuga Sundaram, and the benevolence of the Chancellor, Dr. A.S. Ganesan, and Madam Chancellor, Dr. Anuradha Ganesan, Director, VMRF, I feel proud to welcome our young and dynamic Madam Chancellor for this CME, and I'm honored to have her as our chief guest in this program. We welcome you, ma'am. I'm pleased to welcome our beloved Dean, Professor Kotu, who was a guide, mentor, and constant support for us, and Dr. Vishnu Bhatt, sir, Director of Medical Research, a source of inspiration, and Dr. Mahalakshmi, the mastermind and motivator for the CME. I would like to welcome our MS sir, Dr. Jai Singh, who was always ready to render a helping hand in times of need. And a special welcome to the Vice Principal, Dr. Rajan. And I feel proud to welcome our eminent and born teachers from institutes of national importance. I welcome Dr. Sundari ma'am, Professor of MS Ramaya Medical College, Bangalore, Dr. Muralidhar Pai, Dean and Professor of OG, Sikkim Manipal Institute of Medical Sciences, the HODs, previous HODs of CMC Vellore, Dr. Aruna Ketkari, Dr. Lakshmi Seshadri, and present Chief and HOD, Dr. Lily Varghese. I would like to welcome Dr. Palaniyappan, Professor of Ramachandra Medical College, Poru. A special thanks to Dr. Aruna Madam, who has gone abroad to spend her family time. When I approached her, she told me, ma'am, give me the topic and the slot. I'm ready to do it. That was her involvement in teaching. I extend a warm welcome to all the HODs and my friends, the colleagues of my colleges in Pondicherry, from JIBMA, PIMS, MGMC, Manukula Vinayakar Medical College, Venkateshwara Medical College, and Indira Gandhi Medical College, and Chettinad, and our sister concern, VMRF Salem. And last but not the least, my warm welcome to all the young enthusiastic postgraduates. About 220 have registered from all over the country for this program. And coming to the CME, education is not just filling the pot, but igniting a fire. That is the reason why we have chosen the concept for this PG course as Ignite 2022. Let me quote William Franklin's words: when you tell, we will forget. When you teach, we will remember. When you involve, we will learn. That made me to include all the exam-going postgraduates from all the institutes in and around Pondicherry. We, the teachers, we have opened the door, and the postgraduates, you must enter by yourself. And I can assure you that definitely it is going to be an academic feast, because we have chosen the senior faculties who have been doing the PG training for decades together, and have chosen the faculties who have specialized in fetal medicine, urogynecology, infertility, and gynec oncology. Learning is not achieved without making errors. So the postgraduates, even if you make errors, don't feel depressed, get it corrected, make use of this platform to learn and move forward. Let me end my speech by saying a Japanese proverb: a day spent with a good teacher is better than 1,000 days of diligent study. Thank you.
Thank you, ma'am, for that bright start. Now I request our organizing co-chairperson, highly inspirational Professor Pushpa Kotur, to introduce our Madam Chancellor, Dr. Anuradha Ganesan, to the audience. Over to you, madam.
Thank you, Deepa. I consider it as a proud privilege to introduce our chairman, Madam, Dr. Anuradha Ganesan. who is a director of PMRF since almost a decade and a half. Being herself a medical doctor, trained in a prestigious Kasturba Medical College of Manipal, she has set health and hygiene and education on the top priority and working tirelessly through the platform she has. She's an ardent philanthropist and is associated with various philanthropic organizations. Myself being an active Rotarian for more than 3 decades, I very well understand the passionate feelings of dedicated, committed fellow Rotarian who is internalized the value of Rotary Club fellowship, combined efforts of serve humanity, and diversity with the idea of service. Various people from different countries, different communities, they come together, integrity, who are committed to expect accountability from all the leaders and fellow members and leadership, a global fellowship of individuals. Yes, you are correct. She is a member of Rotary Club since almost a decade, I think. She is a member of Rotary Club of Madras, India. She's committed to idea of service. Some of her projects in Rotary are mainly highlighting how she is concerned about the sanitation and health hygiene, which improves our community's health. And one of her projects is building the toilets in villages, involving students. She's a daughter of her Rotarian parents, and that has made her to work hard towards her achievement, towards her goal and values. What she lived by is inculcated by her parents. She strives to continue their legacy in various ways and got inspired from her mother to evolve as a dedicated social worker. Her other noteworthy credentials, which can be role model for some of us, are volunteer experience. She's also a director of Libera Foundation India. The Libera Foundation is the international non-profit philanthropic organization from UK. For the past 6 years, she is director of that. And she has founded one organization, Tirukural Temmal Enna Mannimolana Muttamil Ayam. This organization she has named after her father, and this is mainly to organize programs to inculcate and nurture Indian culture, especially Tamil culture. She's also a member of Ulaha Tirukural Peravai. So that is Tirukural is a treasure house of worldly knowledge, ethical guidance, and spiritual wisdom. So here we have our chairman, madam, who is young, enthusiastic, and who inspires the young minds, especially our students, and which keeps her going. So here is our chairman, madam, Dr. Anuradha Ganesh.
Thank you, Dr. Pushpa Kotur, for such a lovely introduction. Good afternoon. Good afternoon, everyone present here. Our respected Dean, Dr. P.F. Kotur, the HOD of OBG, and the organizing chairperson of this conference, Dr. R. Sashikala, and then Dr. Pushpa Kotur, organizing co-chair of this conference, Dr. Vishnu Bhatt, Director Medical Research, Dr. V.N. Mahalakshmi, Dean HP, MS, Dr. Jai Singh, Dr. S. Deepa, Professor of OBG, and other esteemed speakers of today's conference, the medical fraternity, faculty, and dear students. It is a pleasure to take part in today's event, a national conference called Ignite 2022, a PG rapid revision course, which is being organized by the Department of OBG at Arubadai Medical College on a virtual platform for 3 days. This academic program is intended to educate the postgraduate students of obstetrics and gynecology throughout the nation on the core concepts of the concerned subject. This program has been planned in a structured and exam-oriented aspect for 3 days, covering all the topics of obstetrics and gynecology in order to master them. So as Dr. Sashikala mentioned, the term Ignite is to probably rekindle and create a spark in all, and remember all the core concepts that, we should always have it in memory with us. So I'm happy to note there has been such a great response for this training program with 220 registered postgraduates across the country. The training is given by 32 eminent resource persons with vast PG teaching experience and from institutions of national repute like CMC Vellore, Manipal, SRMC, MS Ramaya Medical College, JIPMA, etc. On behalf of the management, I extend my warm welcome to all the delegates. It is an honor to have you all visit and be a part of this conference. Indeed, the pandemic has created a vacuum in teaching and learning activities in all aspects of medicine. This conference hopes to fill in the gap and help the students to enhance their subject and clinical skills. It is said that productivity is never an accident. It is always a result of a commitment to excellence, intelligent planning, and focused effort. Success in our own life can be achieved with goal setting, motivation, time management, and personal and professional development. My best wishes to the organizing committee headed by Dr. R. Sashikala, an excellent teacher and clinician with several years of experience and who's very committed to our vocation, and to the rest of the OG department who set up this conference, Dr. Pushpa Kotur, Dr. K.S. Arumati, Dr. Deepa, Dr. Jessie Verghese, Dr. P. Ramya, Dr. Divya, Dr. Saras Jodi. My best wishes to the CME coordinator, Dr. Shushmita Mahapatra, Assistant Professor of Physiology, for all my best wishes for all your efforts. I'm sure this program will help in enhancing the standards of the postgraduates with a great learning experience. I came in, there are such eminent teachers here who, and I don't want to take much of their time, and I just came to give my best wishes to all of y'all. I would like to leave you with a kural from the great poet Thiruvalluvar, Enniya enniyange eidhuva, enniyar thinniyar aga perin. Person of resolute mind and conviction will surely achieve what they aspire and wish and face the challenges of today's world. Both faculty and students have had a lot of disadvantages which the pandemic has posed, but with great resolution, we can overcome. Thank you for the resilience that you have shown throughout this pandemic, and best wishes for a very successful year ahead. Thank you so much for this opportunity.
Thank you, ma'am.
Thank you, ma'am, for your thought-provoking words. Now I request our beloved Dean, AVMC, Professor P.F. Kotu, sir, to address the gathering. Sir, please.
Yeah. Very good afternoon to all the resource persons and the participants. Respected Chief Patron and the Chief Guest for this postgraduate rapid refresher course, Ignite 2022, Madam Dr. Anuradha Ganeshan, and the trio of the organizers, Dr. Shashikala, Dr. Pushpa, and Dr. Deepa, and my colleagues, Professor Vishnu Bhatt, Jai Singh, Professor Mahalakshmi, and other faculty members. As a head of the institution, I have feeling a loss of words to express my thoughts on this occasion. First of all, when you become too much happy, you will have a loss of words. This is what is my present feeling. Now, I just like to tell that this on this virtual platform of Ignite 2022, created here at AVMC by the Department of Obstetrics and Gynecology, I welcome all the resource persons from 8 states, PGs from 8 states, and several medical colleges on this platform, having taken their time to share their expertise. There are, the people who have accomplished in their career, accomplished teachers, accomplished researchers, accomplished academicians. They are here on this platform, and I must compliment the Department of OBG for this. In a couple of sentences, I will say, the idea of igniting the minds of the postgraduates, example postgraduates, was conceived, I think, a couple of months back in our college council meet, when we realized during the peak of COVID pandemic, our postgraduates were at a loss because the hospital was taken over by the government of Pondicherry for offering the COVID patients. Practically, the students had a loss of a clinical experience, clinical teaching. So then we discussed that. Then we, in fact, at this point of time, I must remember our leadership team of Dr. Mahalakshmi, we were telling how about organizing such a, by all the departments. This is what was our dream. Not only OBG, all major departments at least, we will have that idea of conducting this. But the thing is, I'm very, very happy that the Department of OBG has taken that opportunity first and converted that dream, whatever it is, into a reality. And now, when the program automatically got expanded exponentially by so many postgraduates, so many resource persons, which probably beyond what we expected. And it got a lot of enthusiasm for the organizers, and they have coined the program. The today and tomorrow, all the topics I've seen as an undergraduate student, what I studied option gynecology, all DUB, ovarian tumor, primary infertility, male infertility, IUGR, anemia. These are all the common things. All those common things have been brought on this, and they will be addressed by the experienced teachers. And what more can PG can get more than this when he is in the mood of appearing the exam in the next couple of weeks? Then these kind of a sensitization, these kind of a prompt is certainly going to help him. And as our Honorable Chancellor Madam said, that a gap, vacuum which was created during the pandemic, this program will try to fill that. And what I'm telling you, in fact, Professor Shashikala came in the morning to give a invitation. Again, of course, she had invited earlier also. She came to remind probably. Then I said, Madam, hereafter it will be the character of the institution, institutional character. You are so enthusiastic and you are very happy that such a wonderful response has happened. And why it cannot become a AVMC institutional character? That means every year, the Ignite 2022, 2023, 2024, like that, it can go on. I have a personal experience of having, we call it as a PGXL in Karnataka, 27 years uninterruptedly it has been happening. And what is the problem over here? And one thing is, this is virtual platform for the first time conceived probably by the OBG departments. Previously, Madam was telling some MGMC are conducted physical one and all. Of course, we have this blessing in disguise. This virtualization of the education has become a boon, for all of us. Any person from anywhere across the country, anywhere across the globe can be a part of this. This is what we have learned. So I'm sure in the time to come, like our FFF platform, which has become an institutional character, our oration, which is a institutional character, our research day, so many things where AVMC is trying to internalize and offer it to the fraternity. So this also will be, I'm sure, and it will be Ignite 2022 OBG. I hope it will be Ignite 2023 General Medicine. So like that, if you do, it will certainly keep all of us on the foot. And one more thought that is coming to my mind is, Pondicherry has got a conducive atmosphere to have such a kind of activities because it has got 28 medical colleges and about 30 OBG professors. In the city of Pondicherry, in a small city of Pondicherry, we have 30 experience. The minimum number I'm telling, it might be more. So all of us can think of having a common platform and offer the PGs of the country. Now I was very happy that even Madam was proudly telling from Madhya Pradesh, Maharashtra, the students have come. That is, the need is there. When you're really offering something good, the need will be there and automatically you will do something good. And now I said these are some of the thoughts, otherwise I keep on tying. The time given to me is only 4 minutes. So I'm sure that this legacy will be carried forward and the AVMC platform will be very much looked after here by all the postgraduates of all the subjects, as I said. And I make a mention of special mention of the resource persons, Dr. Muralidhar Pai, Dr. Sundari, Dr. Lakshmi Sheshadri, Dr. Aruna Ketkar, they are all from very prestigious colleges, CMC Vellore, MS Ramaiah, then the SRMC. They have taken their time to be a part of this, which will certainly give quite a boost to this program. And a small word of advice. Being a teacher, it is my duty to advise all the postgraduates who have enrolled voluntarily, not compulsory, so voluntarily, to make use of this. So much is in front of you. Interact, provoke the teachers to clarify your queries. Then it will be a fruitful deliberation and it will bring a lot of satisfaction for all of us. With these few words, once again, I wish a very fruitful deliberation to all of the participants. Thank you very much, Deepa.
Thank you, sir. Thank you, sir, for your motivational words. May I now request Dr. Vishnu Bhatt, sir, Director Medical Research, Professor of Pediatrics and Neonatology, to grace this occasion with your motivational words. Sir, please.
Respected Madam Chancellor, Dr. Anuradha Ganesan, Dean, AVMC, Dr. P.F. Kotur, Dr. Mahalakshmi, Dean HPE, Dr. Jaya Singh, Medical Superintendent, Vice Principals, Dr. Rajan, Dr. Arunachalam, Madam Shashikala and Madam Kotur, the Chairperson, Co-Chairperson, Dr. Deepa, the Organizing Secretary, honored speakers and respected delegates. It is nice to see AVMC is organizing this EME program, Ignite 2022. I am sure that it will ignite all our skill and knowledge to give better antenatal and postnatal care and other issues. And I'm sure that this program will go a long way in stimulating our thinking and also expanding our knowledge. There are more than 220 delegates. It indicates the need for such a program. I am sure next 2.5 days, all those who have participated in the program will get the benefit, not only the postgraduates, but also the practicing and obstetrician and gynecologist. We may be knowing more in one field, but definitely we will know less in other field. So when people from different subspecialties talk, I think it will give a wholesome picture. And I wish the program all success. And I will be there in between to listen to the talks also. Best wishes. Thank you very much.
Thank you, sir, for your motivational words. Now I'd like to invite our Dynamic Dean Health Professions Education, Dr. V.N. Mahalakshmi, to share her thoughts in this academic program.
Thank you, Deepa. Good afternoon, everyone. And nice to meet a lot of long-term friends and other esteemed people in this gathering. Actually, just-in-time learning is a concept which is very nice and close to my heart, like especially for the students. When we were analyzing the effects of COVID, the educational impact of COVID, as our Dean Sir said, we found this issue. But since 2019, we have been asking departments that it is a very nice thing to do a just-in-time revision for students. Can you do it? Why? Because first and foremost, it is very responsive to the learner needs. No, the number of 240 people have enrolled for this program. That itself shows that there is a need for such programs in the country. So that is one. So second one is the content plan. No, what is currently being available and which needs to be given. So that is another important aspect. And the program is usually, like, if you see the schedule also what they have made, it is not like you're having one big chunk of or one big mass of information which is being provided, but it is chunked into mini bite-sized pieces. No, so you can take a bite of fibroid, you can take a bite of high-risk obstetric pregnancy and things like that. So that makes it much easier for students to retain. And most importantly, it is just not one mass of information which is being provided. It is actually contextualized by discussing case scenarios, so which makes it stick much more. No? So cognitively, it is much this thing. And most important aspect I feel is the social learning. No? That you are learning from variety of resource persons from across the country, and you are learning with variety of students from across the country. You are not learning alone. So these things make just-in-time learning a very nice concept, and I am very happy that at least one department has taken up this initiative, which we have been putting for quite some time to take it up. And I'm sure that the participants will benefit vastly from the very meticulously planned program content, the cases which are being selected, and also the way in which it is going to be discussed. I wish the program all the best and happy learning to you all. Thank you.
Thank you, ma'am. Now I request our beloved medical superintendent, Professor K. Jaisingh, to address the gathering in this grand occasion. Sir, please.
Thank you, Dr. Deepa. Respected Chief Guest and our beloved Director, Vinaya Missions Research Foundation, Madam Dr. Anuradha Ganesan, beloved Dean Dr. Kotur, who is presiding over this inaugural program of Ignite 2022, Dean HPE Dr. Mahalakshmi, Director of Medical Research Dr. Vishnu Bhatt, Organizing Chairperson of Ignite 2022 Dr. Sasikala, and the head who is head department of OBG AVMC, co-chairperson Dr. Pushpa Kotur, Dr. Deepa, Professor OBG AVMCH, learned moderators of today, tomorrow, and day after tomorrow presentations of Ignite 2022, enthusiastic presenters, and other participants. Good afternoon to all. It gives me an immense pleasure to felicitate this postgraduate revision program of OBG, which is going to be very useful to all the postgraduates of OBG to face their university examination in a very confident manner. And I should also congratulate all the organizers for choosing these very important topics from the examination point of view, as well as from the day-to-day practice point of view also. I'm a physician by training, and I'm happy to note that there are 4 medicine-related topics to be presented today and tomorrow and day after tomorrow. Hyperglycemia in pregnancy, anemia complicating pregnancy, heart disease complicating pregnancy, hypertensive disorders in pregnancy. As a physician, I have dealt with all these sort of cases, patients in all the hospitals I have worked over the past 35 years. To say a few words about these complications in pregnancy, the overall prevalence of gestational diabetes is 1.3, and the prevalence increases with the age from 1% in the age group of 15 to 19 years to 2.4 in the age group of 35 years and above. A study by Nutritional Foundation of India and ICMR Task Force observed the prevalence of anemia as 84.9% among the pregnant women in India. The prevalence of heart disease in pregnancy in a study in India was 2.32%, whereas in a study done abroad was 4.3%. In India, the incidence of preeclampsia is reported to be 8 to 10% among pregnant women. According to a study, the prevalence of hypertensive disorders of pregnancy was 7.8% with preeclampsia in 5.4% of the study population in India. So to that extent, these topics are very important topics which have to be discussed in a forum like this. These topics are very important topics to be well known to the budding obstetricians of a developing country like India. During their career, these postgraduates will be encountering many such cases in India, especially in rural India, who are yet to get even basic medical facilities in their life. I understand many more interesting topics are also to be presented in the program. I'm sure the program will enlighten all the obstetric gynecology postgraduates, and I request all the postgraduates to learn their subject bearing the poor rural women population of India in the back of their mind. I wish the postgraduate session program Ignite 2022 ignite a fire to serve for the poor and rural women folk of India. I wish the program a grand success. Thank you. Thank you, Dr. Deepa. Over to you.
Thank you, sir. Now we are at the end of the inauguration program of Ignite 2022. Myself, Dr. Deepa, feel privileged to present the vote of thanks. On behalf of Department of Obstetrics and Gynecology, I am deeply honored to thank all our resource persons across the nation who have readily accepted our invitation and joined us in bringing up the competent postgraduates by our 3 days training program. Thank you, ma'am and sirs. I extend my sense of gratitude to our Honorable Chancellor, VMRF, Dr. A.S. Ganeshan, for his motivation in organizing this course. It is my pleasure to thank our Madam Chancellor and Director VMRF, Dr. Anuradha Ganeshan, for her gracious presence and inspirational words. Thank you, ma'am. And a special thanks to Mr. Suresh Samvel, Member Board of Management, VMRF. I am delighted to offer my sincere thanks to our beloved Dean, Professor P.F. Kotur, for his enthusiastic support and encouragement. It is my pleasure to thank our dynamic Dean Health Professions Education, Professor V.N. Mahalakshmi, for her motivation and guidance in organizing this event. My sincere thanks to Professor Vishnu Bhatt, Director Medical Research at AVMC, for his encouragement always. I am pleased to thank our Medical Superintendent, Professor K. Jaisingh, for his support. I would like to extend my thanks to all the heads of the departments, faculty members, postgraduates who have registered for this course to enlighten themselves. Finally, I thank the audiovisual people and other clerical staff who have helped us. Thank you, one and all. Thank you. Now we will move on to the scientific session.
A very good afternoon to everyone. I'm Dr. Divya, Assistant Professor in the Department of Obstetrics and Gynecology at Arbor Medical College. Now I will be the Master of Ceremonies. Now we'll start our academic scientific session. The first topic of today is abnormal uterine bleeding. The moderators for this session are Dr. Ma'am. The presenters are Dr. Dipansha Bajpai and Dr. Nandini from Arbor Medical College, Pondicherry. I feel extremely privileged to introduce.
Cannot record microphone in use and
I feel extremely privileged to introduce Dr. Aruna Kekre ma'am. She's a former professor and HOD, Department of Obstetrics and Gynecology, and head of Urogynecology Unit, CMC Vellore. Madam is currently the senior consultant HOD of Narvi Hospitals, Henry Ford Health System, Vellore. Madam has published more than 50 in indexed journals and written chapters in textbooks. Madam is an eminent teacher with a teaching experience of more than 3 decades. Thank you, Madam. And Doctor, I feel privileged in introducing Dr. Sasikala ma'am. Madam is the organizing chairperson of our Ignite 2022. Madam is a professor and head of the department OG, Arbor Medical College. Madam, her alma mater is Madurai Medical College. Madam is retired as professor and HOD from Government Medical College. She's a Senate member of Tamil Nadu Dr. MGR Medical University prior to superannuation. And Madam is a member of PG Board of Studies, Pondicherry too. Welcome, ma'am. PGs, the presenters can now introduce themselves to the briefest and they can start the presentation.
Good afternoon, everyone. I am Dipansha Bajpai from Department of OG. Good afternoon, everyone. I'm Dr. Nandini from Department of Obs and Gynae.
Yeah, good morning, Dipansha. Good morning, Nandini.
Good morning, ma'am.
Ma'am is in UK, so she wishes good morning. I have to say good afternoon.
Oh, sorry. Anyway, thank you, Dr. Shashikala.
Okay. Yes, madam. Nice to have you here, madam. Okay.
And also accommodating me at the right time for myself. Thank you so much.
Thank you, ma'am.
Ma'am, shall we start, ma'am? Ma'am, shall we start?
Yes, ma. Yes, ma. You can start.
Okay. Mrs. XYZ, 40 years old, hailing from Kadlur, housewife by occupation, belonging to low socioeconomic status, para 2 life 2, previous normal deliveries, sterilized. Came to OPD with chief complaints of regular, prolonged, heavy menstrual bleeding for 6 months. His presenting illness, she was apparently all right 6 months back when she developed heavy and prolonged menstrual bleeding. She was having regular cycles. She used to bleed once in 28 days for 10 days, changing 8 to 10 pads per day. Associated with clots and dysmenorrhea. History of flooding present, necessitating change pad night. So this is PO system 1, in which we are going to plot the clinical features with which our patient has presented to us.
Monica, the reception is not good, ma'am. Reception சரியில்லடா அங்கேருந்து இங்க உட்கார சொல்லிடுவாங்க. இவங்க இப்ப பேசுறது உட்காந்து கேட்கவே இல்லடா. இங்க ஏத்துரும்.
Ma'am, am I audible?
Yeah, but your voice is broken.
In between it is breaking, ma. Sit in a place where you get a good connection.
Your voice is breaking.
Ma'am, am I audible?
Yes, ma'am. Now you are audible.
Audible, ma? Yes, you can proceed.
Okay.
Okay, go ahead.
I'll present from the start, ma'am.
No, no, you go ahead. No, no, don't come to the.
Okay.
Yeah. Okay.
So this is FIGO AUB system 1, where I am going to we have plotted clinical features of the case which has come to us. So the frequency was normal, that is 28 to 30 days. So we have marked in normal column. Then the duration was prolonged, that is 10 days for our case. So it is prolonged. Regularity, how we are going to calculate regularity? For our case, the regularity was 4 to 5 days. That is the difference between the shortest and longest cycle in 1 year, last 1 year. The flow of volume according to patient perception was heavy. So we have marked here in heavy. The patient did not complain of any intermenstrual bleeding, so it is none. And the patient was not on any hormone medication, so that is not applicable. Going ahead, no history of intermenstrual bleeding, no history of postcoital bleeding, no history of dyspareunia, no history of abnormal discharge per vaginum, no history of heat or cold intolerance, weight loss, weight gain, tremors, palpitations. No history of acne, hirsutism, no history of chronic cough or weight loss, no history of secretions from breast, no history of loss of appetite, no history of polyuria, polyphagia, polydipsia, no history of urinary and defecatory issues. Going to her menstrual cycle, menarche attained at 13 years of age. Previous cycles were regular. She used to bleed once in 28 to 30 days for 3 to 5 days with average flow. Her last menstrual period was 18/2/2022. Marital history, married since 20 years, non-consanguineous marriage, living with husband. Obstetric history, she is para 2, live 2, both full-term normal deliveries in hospital. Last childbirth is 14 years. No history of intake of any OCPs for spacing of pregnancy. Husband used barrier contraception. Has undergone puerperal sterilization after second delivery. Past history, past medical history, diagnosed to be diabetic for 1 year on oral hypoglycemic agent. At present, the glycemic control is good. No other underlying medical disorders like hypertension or thyroid disorders. No history of PCOS, no history of COVID infection, no history of prior blood transfusion, no history suggestive of coagulation disorders, no history of drug intake of drugs like anticoagulants, tricyclic antidepressants. Past surgical history, apart from sterilization, did not undergo any surgery. Family history, no family history of diabetes, hypertension, thyroid disorders, no family history of endometrial, colorectal, breast, ovarian, other GI malignancies, no family history of hematological and coagulation disorders. Personal history, mixed diet, normal appetite, normal bowel and bladder habits, normal sleep pattern, no history of addiction, no history of any allergy. Treatment history, she went to private practitioner 3 months back and was given a drug for 5 days, after which bleeding was reduced. She was not on any regular treatment. Iron supplementation was given. USG was not done.
Okay, Dipansha.
Yes.
Can we just stop here for the history sake?
Yes, ma'am.
Yeah. Now you asked her history of coagulation disorder.
Yes, ma'am.
Right? No history of coagulopathy. Do you think this patient has history of coagulopathy? Anything suggestive of coagulopathy? Or I would put the question in a different way. In which patient would you suspect patient having coagulopathy or coagulation disorder?
In adolescents, we usually suspect patients having coagulation disorders, ma'am. They will manifest from their childhood only.
Okay, if the patient has puberty menorrhagia,
Puberty
in
menorrhagia.
terms of von
Yes, ma'am.
Willebrand's of hyperthor or thrombocytopenic purpura. But what is the other history? She's 40 years old. What is the history which will be suggestive of coagulopathy?
Okay, ma'am. History of heavy menstrual bleeding since menarche, we should ask, ma'am. Then history of PPH, we should ask, ma'am. Then history of any bleeding manifestation during any surgery or dental extraction, we should ask, ma'am. Any family history of coagulation disorders, we should ask. Then any frequent gum bleeding, we should ask. Then epistaxis, we should ask. And easy bruises, we should ask, ma'am.
Petiki. Okay, good. Well answered. Okay. Second question is, you asked her about history of polycystic ovary. Right? Is it relevant in this case?
No, ma'am. Actually,
when would you consider a patient having polycystic ovary and bleeding disorder? Is this history suggestive of that?
Actually, if the patient would have come to us with a period of amenorrhea followed by heavy menstrual bleeding, then if I would have asked, then it would have related much better, ma'am.
Okay, usually there are anovulatory cycles. A long period of amenorrhea followed by bleeding is suggestive of anovulatory cycle. One of the possibilities is polycystic ovary. Are you worried about patients with chronic anovulation who presents later on with abnormal bleeding?
Yes, ma'am. They can land up into endometrial hyperplasia, ma'am.
Yeah, there is a fear of endometrial hyperplasia, and later on it could be a history of endometrial malignancy.
Yes, ma'am.
Number 3, in your history, you asked regarding sterilization. She's already sterilized. So any specific reason her husband is using barrier contraception?
For spacing of pregnancy, she didn't use any OCPs, ma'am. Husband was using barrier contraception then, ma'am. Like that I was telling. And
because
if
she
it
got
was
sterilized after the second childbirth.
Yes, ma'am. So previously he was using, ma'am. And
okay,
if it was
not presently.
Not present.
Okay. Prevention of sexually transmitted diseases one of the reasons why patients can use a barrier contraception.
Dual
contraception. Okay. Fine. So I think your history was pretty well taken, and your answering to the questions that I asked also was quite good. Dr. Shashikala, would you like to ask anything in the history?
Yes, Dipansha, if the lady gives you a history that she's on a combined OZ pills for a period of 4 or 5 years, tell me the genital tract malignancy she will be protected from.
Ma'am, she'll be protected from endometrial cancer, ma'am, ovarian cancer, colorectal cancer, ma'am.
What is the malignancy she is likely to develop, ma'am?
Cervical cancer, ma'am.
Breast cancer. Be specific in your answer. If it happens
adenocarcinoma of cervix.
In adenocarcinoma, what is the type?
Below glandular, ma'am.
Below glandular type when she is on combined OCP. Okay.
Okay, Dipansha, you said the patient has got heavy menstrual blood loss. What are the features which suggest that, yes, I do understand as a clinician, I know that this patient has got heavy menstrual blood loss. What is the history that you would like to elicit?
The number of pads she is changing, I would like to know, ma'am. And according to like how many, whether she is passing clots or not. History of changing of pad during the night, like flooding during the night, that I would like to ask, ma'am. Any episode of excessive bleeding which is hampering her physical, social, emotional, or material quality of life, then we will label her as like she's having heavy menstrual bleeding.
Okay, she'll also be taking off from her work when she's got heavy menstrual blood loss.
Yes, ma'am.
Right? Her work, she may have to take off from work when she's got heavy bleeding, easy fatigability, tiredness, exhaustion, breathlessness if she's in failure. All this history should be included to substantiate your findings saying that this patient has got heavy menstrual blood loss. Okay? That has to be included.
So as per the recent guidelines, the quantity of bleeding is not given importance. Okay, more than 80 ml, less than 15 ml. Rather than that, the amount of bleeding which affects her quality of life is given importance. The perspective. Okay, ma, proceed.
By definition, how do you know that this patient has got abnormal uterine bleeding? What do you differ from the history? What do you say that this patient has got this is a tentative diagnosis of what?
Okay, ma'am. So what is AUB is any bleeding from the uterine corpus which is deviated from the normal menstrual cycle in frequency, regularity, or duration, which is
Okay, what is the
happening here,
normal
ma'am.
frequency?
20
In a patient
normal
is 40 years old.
Normal frequency will be 28 to 30 days, ma'am. Or sorry, 24 to 38 days, ma'am.
38.
24 to 38
24.
days.
So if it comes before 24 days, you know the patient has got
Frequent menstrual cycle.
If it is beyond 38 days, the cycles are
Infrequent.
delayed. Okay. Frequency, volume, normally by definition, how much of bleeding is supposed to be excessive?
Actually, initially it was more than 80 ml, ma'am. Now it is based on patient perception.
Correct.
So that is this thing, ma'am. Then duration, ma'am, more than or equal to 8 days is abnormal, ma'am. Sorry, less than or equal to 8 days is normal, and more than 8 days is abnormal, ma'am.
Okay, so she qualifies into having abnormal uterine bleeding. Okay, fine.
Yes.
Go ahead.
Okay, ma'am. I'll go on to general examination, ma'am. So she was obese, ma'am. General condition fair. All other vitals were normal, ma'am. Mildly anemic. Pedal edema was absent. No lymphadenopathy. Thyroid and breast was normal. Systemic examination. CNS, CVS, RS was clinically normal. On per-abdomen examination on inspection, sterilization scar was present, which was healthy. No dilated veins, scars, or sinuses was there. Hernial orifices were free. On palpation, soft, the abdomen was soft, non-tender. Uterus was just palpable, and there was no organomegaly.
So when you say just palpable, it corresponds to how many weeks?
12 weeks, ma'am.
Okay.
Systemic examination, local examination normal. On per speculum examination, cervix and vagina was healthy. No bleeding through was seen. Pap smear was taken. Bimanual examination, uterus.
Apart from the cervix being healthy, vagina being healthy, no bleeding, is there anything specific you would like to see in a patient who has got abnormal uterine bleeding? Not just heavy menstrual blood loss, but even intermenstrual bleeding, postcoital bleeding. What would you like to see?
Any polyp or any lesion on the cervix can lead to intermenstrual bleeding, ma'am, which will be, if it is a cervical lesion, it will be random, ma'am.
Okay, so it could be either a cervical polyp or it could be a cervical ectropion, which can lead to postmenopausal or intermenstrual bleeding. Okay. Go back.
Go back, ma. The previous slide.
Yes, ma'am. One second.
Okay, uterus.
Okay. Bimanual examination, uterus was uniformly enlarged, antivoted, about 12 week size, slightly tender, mobile, and fornices were free.
What do you mean by uniformly enlarged? Is it important to know whether it is uniformly or irregularly enlarged?
Ma'am, yes, ma'am. Like to differentiate between whether, like, where is the, if we are suspecting a fibroid, for example, where is the fibroid, we'll get to know. And if we are suspecting adenomyosis, if it is uniformly enlarged, that tells us that it is diffuse adenomyosis. If any particular fornix we are feeling any bulge is there, or we are feeling any fullness is there, then we'll tell like it can be a focal adenomyosis also.
Okay, what else is missing in your clinical examination? On BM is what? Bimanual.
Bimanual exam.
Okay, per vaginal examination. So what is missing here? You said uterus is slightly tender. There is nothing like slightly tender or more tender. It is tender or it is not tender?
It was tender, ma'am.
So if the uterus is tender, what are the situations where you can get uterine tenderness?
Adenomyosis I can get, ma'am.
Okay.
Endometriosis I can get, ma'am. Any pyometra, if it is there, I can get, ma'am.
Pelvic inflammatory disease.
Pelvic.
Right. So when you're suspecting pelvic inflammatory disease with a tender uterus or adenomyosis with a tender uterus, is there anything particular you would like to see?
So in pelvic inflammatory disease, I would like to see any cervical motion tenderness is there.
Correct. The cervical excitation, is it positive or negative? And always, as a clinician and as a gynecologist, I think it's extremely important, irrespective of whatever you're doing a pelvic examination for, you need to comment on the pouch of Douglas.
Okay.
Okay. Whether there is any nodularity in the pouch of Douglas, whether there is any induration in the pouch of Douglas, and whether there is any mass in the pouch of Douglas as a routine. Okay, and you need
Okay,
to know
ma'am.
why you're doing it for. Especially in a patient who's got a fibroid uterus, you're commenting on the end of on the pouch of Douglas. You may find nodularity, you may find tender shorty nodules, you may find cervical excitation is positive. What does it mean?
If a nodularity is there, ma'am.
Nodularity, indulation, tenderness, cervical excitation being positive. What can it be?
Endometriosis, ma'am.
It can be, especially with a fibroid, the patient can have endometriosis.
Endometriosis.
Okay, correct.
Then on per rectal examination, ma'am, rectal mucosa was free and there was no nodularity, ma'am.
Okay.
So my provisional diagnosis, ma'am, Mrs. XYZ, 40-year-old, para 2, live 2, sterilized, a case of chronic abnormal uterine bleeding, suspecting structural abnormalities with diabetes, with moderate anemia, admitted for evaluation.
Okay. You need not write the structural abnormality.
Okay.
Okay. That will come with your clinical examination and your further evaluation. So what you correctly written is para 2 living 2 with AUB, diabetes and moderate anemia. Okay. So what do you think this patient has? Like before you go on for evaluation, what do you think the cause of abnormal uterine bleeding can be?
Okay, ma'am. So since she has come to us with heavy and prolonged bleeding, and on bimanual examination, the uterus sizes like up to 12 weeks, it can be a structural abnormality, ma'am. It can be, since on per speculum, I have not seen any polyp. So there is no cervical polyp, but there can be any fibroid or submucosal polyp inside, ma'am. And adenomyosis can be there, ma'am, or any other fibroid.
Polyp, what other history would you get?
If
an endometrial polyp, what
okay,
is the other history that you would like to get?
Dysmenorrhea will be there, ma'am.
Spasmodic
Spasmodic type of dysmenorrhea will be there, ma'am.
Okay. Did she have, you have in your history, you have just mentioned dysmenorrhea, number
It was
1.
congestive type of dysmenorrhea, ma'am.
Okay, number 1, you should not mention dysmenorrhea. You need to mention pain during periods or before periods.
Okay.
In your history. Okay. And you need to later on let us know whether it's a congestive or a spasmodic type of dysmenorrhea.
Okay.
Okay. What is it?
For my patient, it was congestive, ma'am.
A congestive type of dysmenorrhea. Okay, fine. So if it is a polyp, how do you know that the patient has got an endometrial polyp on history?
On history. She will present to us with AUB, ma'am, with spasmodic type of.
No, not AUB. What do you mean by AUB?
It can be heavy and prolonged menstrual bleeding, ma'am.
Okay.
Then
or
after
it can
that,
be intermenstrual bleeding.
Intermenstrual bleeding, ma'am.
Okay.
Then there will be spasmodic type of dysmenorrhea, ma'am.
Okay.
If that endometrial polyp got infected, then there can be a foul smelling discharge, abnormal vaginal.
Very unlikely for an endometrial polyp.
Endometrial polyp to get.
Yeah? It's an endocervical polyp.
If it is endocervical, it is okay.
Okay. So if you think in terms of polyp, clinical history tells you that this is a polyp. Is there any other way by which you can diagnose other than ultrasonography?
Saline, but that
no,
saline
other than any investigation. Patient has come to you saying that she has taken oral contraceptive pills, and despite of that, her symptoms have not subsided. She's still having intermenstrual bleeding. So a patient who does not respond to oral contraceptive pills, who has got spasmodic dysmenorrhea, who has got heavy menstrual bleeding, and who has got intermenstrual bleeding, unless proved otherwise, think in terms of a submucous fibroid. Okay, you know the classification of a submucous fibroid?
Submucous fibroid, ma'am. Yes, ma'am. It is.
What is the classification?
It is a subclassification of FIGO only, ma'am. 0, 1, 2, and 3 it is, ma'am. 0 is pedunculated submucosal fibroid, ma'am. 1 is submucosal fibroid less than 50% intramural. 2 is submucosal fibroid more than or equal to 50% intramural, ma'am. 3 is 100% intramural but touching the endometrium. Like it is submucosal but 100% intramural.
That is 3.
3, ma'am.
What is the clinical significance of FIGO type 3?
Of 3, ma'am. The patient can present to us with infertility also, ma'am.
Okay. Apart from infertility, how does it interfere with your management?
Contractility of the uterus will be affected, ma'am.
No, Dipansha, if a patient has got a subtype 3 with distortion of the endometrial cavity,
we cannot give LNG IUCDs in such patients.
Very good. Yeah. So insertion of LNG will not be possible. And number 2, if you insert it somewhere or the other, you have inserted the in the endometrial cavity, there is an increased chance of expulsion.
Okay.
So that is what is to be kept in mind when you have got a type 3 submucous fibroid. Okay, fine. Okay. Go ahead.
I would like to do
Dipansha?
investigation. Yes, ma'am.
Dipansha,
Yes, ma'am.
what is the primary, secondary, and tertiary methods of classifying a
Classifying
fibroid, ma?
Okay, ma'am. Primary is we are just going to do a scan and tell whether the fibroid is there or not, present or absent. In secondary, we are going to tell whether it is submucosal, SM, or it is others. And third one, like tertiary, we are going to classify from 0 to 8, ma'am. Which one is it?
Okay. If it happens to be a cervical or a broad ligament fibroid,
8,
what's the
ma'am.
number? Okay.
8.
What do you mean by a hybrid, ma?
Hybrid meaning, for example, they have given like 2-5. So 2 will tell us the relationship with the endometrium and 5 will tell us the relationship with the serosum.
Okay.
Shall I
Is a
proceed?
patient with a broad ligament fibroid, are they symptomatic?
They can have pelvic pain, they can have, ma'am.
Okay, chronic
And
pelvic
urinary retention can be there, ma'am.
Urinary retention is not very common with
If it is very big, then only. Otherwise, it won't be there, ma'am.
So it doesn't usually a broad ligament fibroid, unless it is
Won't
associated
have-
with a uterine fibroid, is usually asymptomatic. How do you then diagnose it?
It is an incidental finding, ma'am.
Okay, when you do a PV and you find a broad ligament fibroid, what is one important thing that you would like? It's a large broad ligament fibroid. What is the thing that you need to know before you do the surgery or before you operate?
Whether it is a true broad ligament fibroid or it is a false broad ligament fibroid, ma'am.
That usually you cannot tell unless you open.
Unless we open.
Right?
Okay, ma'am.
Is there any way by which you know that there is any pressure effect on the fibroid?
Intravenous, like.
Usually a broad ligament will displace the ureter either laterally or medially. It can compress it or it can trap the ureter. The ureter can get trapped into the fibroid and produce back pressure changes. So you need to know whether there is any associated hydroureteral necrosis. Okay, fine. So if it is not a polyp, what could it be?
It for our case you are asking, ma'am.
Can you speak loudly?
Can you hear me, ma'am, now? For our case you are asking, ma'am.
Yeah. So one of the differential diagnoses could be a
polyp, then leiomyoma, ma'am, adenomyosis, ma'am.
Okay.
And then it can be endometrial hyperplasia, ma'am. As it is uniformly enlarged and just 12 weeks size. So it is. It can be endometrial hyperplasia or malignancy that we have to rule out.
Okay.
Other than
what type of bleeding this patient has got?
Type of bleed.
Is it ovulatory or anovulatory?
It is regular, ma'am. It is ovulatory only.
It's an ovulatory type of bleeding. Okay. So these are the structural anomalies that you could
suspect.
These are which you
the
consider.
structural abnormalities and
Do you think
non-structural.
this patient will have an endometrial hyperplasia or endometrial malignancy?
She might have, ma'am. 44
What is the
year
risk
old.
factor in this patient?
Diabetes
what is
is
the
there,
risk
ma'am.
factor in the patient to have endometrial hyperplasia or malignancy?
Okay, ma'am. So excessive estrogen exposure in the form of early menarche, late menopause. This is in general, I am telling, ma'am.
So pertaining to your case, madam is asking, ma. In your case, tell me the high risk factors.
In our case, it is obesity, ma'am. Like her BMI is high, ma'am. She is a diabetic, ma'am. And these two are like that.
Okay. She's a multiparous lady. She's para 2 living 2.
That is protective, ma'am.
It's
Nulliparity will be.
Yeah, it's a protective. So only risk factor which you consider is being obese and diabetic.
Yes.
Okay. So there is a point. What are the other risk factor for developing endometrial hyperplasia?
Okay, ma'am. So we'll start with excessive estrogen exposure. In that, there will be early menarche, late menopause, nulliparity, PCOS.
Not PCOS. It is chronic anovulation.
Chronic anovulation.
All patients with chronic anovulation
won't be PCOS.
Okay. So it's chronic anovulation. Okay. So you are worried about endometrial hyperplasia in this patient.
Yes.
Right? You have. Okay. Now, how will you investigate her?
I'll do general investigation. I'll divide the investigations into general investigations and specific investigation pertaining to my case, ma'am. For general investigations, I will send, since she was mildly anemic, I'll like to send hemoglobin, hematocrit, blood grouping and typing. BT-CT platelet I would like to send, ma'am. Since she is diabetic.
Why do you want to see BT-CT platelets? You only said
in this
there is no
case,
history of coagulopathy.
sorry, ma'am. Sorry, ma'am. In this case, I won't.
I mean, I have seen it is a second habit to send BT-CT, PT, APTT, everything has been sent. So it is not really rational enough to, it's not important to send it. One breath you say there is no coagulopathy, in second breath you're saying I want to send the investigation. So it may not be ideal. You're suspecting, yes. If you're not suspecting, then you're not going to be wise at the end of it. Okay.
Okay. And since she's
TSH?
What, ma'am? Hello, ma'am.
Would you like to send TSH?
Yes, ma'am. Since she is diabetic, I would like to send FBS, PPS, HbA1c. I would like to send TSH. Yes, ma'am. TSH also I would like to send.
You like, because hypothyroidism,
hypothyroidism can cause heavy menstrual bleeding.
Okay, fine. You've seen that the hemoglobin is 5 gram%.
Okay.
What would you like to do?
Like investigations, like treatment only you are asking, ma'am?
No, I'm asking you, you've done hemoglobin. Hemoglobin is 5.
Okay, ma'am.
So what will you do?
And
what is so difficult about it, Dipansha? You've been so good in answering.
I would like investigations. Which other investigations I would like to see?
I'm asking you.
Treatment you are asking, ma'am.
Hemoglobin of 5.
I will transfuse blood, ma'am.
So what is it so difficult?
No, sorry.
Huh? Okay. So you transfuse her, make sure she builds up a hemoglobin and then decide. If she's okay, fine. What else? What other investigation you do?
In our case, you are asking, ma'am?
Yes.
Okay.
Yes.
Okay, ma'am. For a specific investigation, I would like to do a transabdominal sonography and a transvaginal sonography, ma'am.
Okay. Why do you want to do a transabdominal sonography? She's so obese.
Okay, ma'am. So we can just go for.
But
if we are okay, ma'am. We can just go for transvaginal sonography.
Yeah, I mean, you can do a transvaginal. You can later on do a transabdominal if you want to look at the kidneys or the upper abdomen. But transvaginal high resolution ultrasound would give you a better idea about what you're dealing with. All right. You mentioned about Pap Smear as well. Did you mention that?
Yes, ma'am.
You did. Okay. You've already taken Pap Smear.
Yes.
Okay. So now, what do you expect on a? Have you done a TVS? Do you have the investigation with you?
Yes, ma'am.
Okay.
Okay. Yes, ma'am. Actually, TBS was done, ma'am. In that, but specifically on endometrial thickness, only the comment was, ma'am. The endometrial thickness was homogeneous. It was 12 mm, ma'am. That much only I have like there was.
Is it important to know what the endometrial thickness is in a patient who is premenopausal? Is there a cutoff? Because you mentioned that, and you again mentioning that I looked at the endometrial thickness. So is that going to tell you, or is that going to tailor your investigation or your management? It may be 12, it can be 18, it can be 5, it can be 6, it can be anything. So in a premenopausal patient, there is no cutoff. As against in a postmenopausal, the cutoff is 4 millimeters. Okay. Here your 12 millimeters just says that it is probably a proliferating type of endometrium. Nothing much. Okay. Interrupted and irregular junctional zone. What are the typical findings of adenomyosis?
Okay, ma'am. So there is a morphological uterus sonographic assessment, according to which there are 8 things. In that, out of which 8 things, if there are more than or equal to 2, we are going to diagnose as adenomyosis. First is asymmetrical myometrial thickening. Second is myometrial cyst. Third is hyperechoic islands. Fourth is fan-shaped shadowing. Fifth is subendometrial fan-shaped shadowing, ma'am.
Okay.
Then subendometrial buds and lines, ma'am. Translesional vascularity, irregular junctional zone, and interrupted junctional zone. Out of this 8, anything more than 2 should be there to diagnose as adenomyosis.
Okay. One important point I would like to highlight here in the exam for all postgraduates is, do not say there are 8 points, because in the exam, invariably you will forget 2. Okay. So you just say these are the things which have to be looked at. Don't specifically say 6 or 7 or 8, because in exam intention you will forget 2. And if you forget 2 without saying 8, it is all right. Having said 8, you have to tell what the 8 are, which you have rightly said now. Okay. So this tells you that this patient has got adenomyosis.
Yes,
Okay. Fine. Anything else?
Here in this, that is only significant, ma'am.
Okay.
For this here, ma'am.
Fine. Now what are you going to do?
For this case, since she is having heavy and she is AUB A, ma'am. So I would first like to proceed with medical line of management, ma'am.
Okay. Dipansha,
yes,
you mentioned about a couple of minutes before that I am worried of endometrial hyperplasia in this patient.
Oh, sorry, ma'am. Sorry, ma'am. I want to do endometrial sampling, ma'am.
Okay. What are the various ways by which you can do endometrial sampling?
We can do office biopsy with pimples. We can.
How many minutes do we have?
Madam, 12 minutes more, madam.
Okay.
12 minutes.
Okay. Okay.
So office biopsy, ma'am, pimples biopsy, Carmen's cannula we can do. Then we can do DNC also, ma'am, and hysteroscopic guided endometrial biopsy also we can do.
Okay. What would you suggest? I mean, there are so many ways of doing. What would you do?
Pimples, I would like to go.
Okay. What is the justification of doing pipple?
It is like less time consuming. We need not give. It is OPD procedure, ma'am. We need not give. We need not give any we can just give a local anesthesia, ma'am. So
do pipple under local anesthesia?
We can like.
No. You do it under local anesthesia. That's an advantage.
No
of pipple.
need.
It's an operation procedure. You can do it without cervical dilatation. You don't even have to hold the anterior lip of the cervix with anything. She's multiparous.
Internal os will be open.
You've got an endometrial thickness of 12 millimeters. It's a very chunky endometrium. You're not going to miss out anything. And number 2, you can do it very easily with a very good specificity and sensitivity. Okay. So I think what you rightly said is pipple endometrial sampling is quite good. Okay. So do you have the biopsy report with this?
The report is awaited, ma'am.
Is
awaited, ma'am.
Is awaited. What do you expect the report to be? So you will do it. What are the other indications of doing endometrial sampling in a patient?
All the high risk. Okay, ma'am. All the patients with high risk factors for endometrial hyperplasia, like
okay, you mentioned that. You already said that. Any other indication of doing endometrial sampling?
Lynch syndrome. If the patient is having a history of Lynch syndrome or any medical disorders like
that, you already said risk factors. In a patient without any risk factor, would you consider doing an endometrial sampling?
Yes. For example, a patient has come to us with postmenopausal bleeding, ma'am, and
no. Madam is talking about your case.
Okay.
Dipansha, number 1. Postmenopausal bleeding does not come into abnormal uterine bleeding. Bleeding in pregnancy does not come into abnormal uterine bleeding. Abnormal uterine bleeding is when you have excluded pregnancy in a premenopausal, in a patient with reproductive age, she has this irregularity. So postmenopausal, don't confuse. So in a patient who has absolutely no risk factor, but still you would like to do.
If there is persistent AUB, patient is not medical management is not, she is not responding to medical management, ma'am.
Okay, that is one. And according to the ACOG and according to the FOX, you need to do endometrial sampling for a patient above the age of 40. Okay, some books mention 45.
45.
But above 40 is an indication because you don't know. Patients even without risk factor can have endometrial hyperplasia. All right, so don't forget that this patient definitely needs an endometrial hyperplasia, endometrial sampling. And what histopathology would you expect?
It's 12 mm, ma'am. Secretory, if there is no this thing, I'll expect secretory, ma'am.
Okay, so it can be either proliferative or it can be secretory or it can be in an endometrial hyperplasia. What type of endometrial, according to the endometrial intraepithelial neoplasia, what is the classification of endometrial hyperplasia?
It is only endometrial hyperplasia with atypia and endometrial hyperplasia without atypia, ma'am.
Okay, that's all. It is simple and complex. There is nothing with atypia or without atypia, right? So if the histopathology comes as
it is with atypia and without atypia, ma'am. Simple and complex.
If the histopathology comes as proliferative endometrium, what will you do? Or normal endometrium, no evidence of hyperplasia, no evidence of malignancy. what is the treatment you would like to do?
I will like to give progesterones, ma'am. If it is endometrial hyperplasia with atypia, and I would like to give progesterone, ma'am, medroxyprogesterone acetate 10 to 20 milligram TDS for for 6 months. I can give, ma'am. After 6 months, I can do again repeated endometrial sampling. If the sampling first thing is I can give medroxyprogesterone acetate, and another thing.
Why do you want to give medroxyprogesterone acetate for this patient?
What is the other way by which you can give progesterone, ma?
Levonorgestrel IUCD I can give.
Is there any role of giving tranexamic acid? She's got only bleeding for 7 or 8 days. You can give a tranexamic acid as a first line of your histopathology is normal, her hemoglobin is all right, or even if is anemia an indication of, or is anemia a contraindication for giving medical treatment?
No, ma'am, we can give simultaneously.
You can give. So even if the patient is anemic, you treat anemia and make sure that you treat her properly so that she doesn't have another bout of bleeding. So it's not a, but if a patient is anemic despite of medical treatment, then that becomes an indication for definitive treatment. So here, I would rather start her on tranexamic acid 500 milligram 3 times a day, which is an antifibrinolytic, and see for the next 2 or 3 cycles whether she's all right or not. So that would be probably, you may not be able to give antifibrinolytic or tranexamic acid, mefenamic acid if the patient is bleeding for 15 days, 18 days. But a patient bleeding for 6 to 7 days, I think you can give a tranexamic acid and mefenamic acid combination for about 2 months, 2 cycles, and see how she responds. Okay, she's responded very well, but still she has a bit of bleeding which she would like you to take care of. So what would you do? She's not responded very well to tranexamic acid. Say she's not responded.
Then we can, this was non-hormonal treatment, ma'am. We can change to hormonal treatment, ma'am.
Okay.
In hormonal treatment, we can give either progestrogens or combined oral contraceptives or LNG IUCD, ma'am.
Okay.
There's 3 options.
Okay. Fine. What is the advantage? You said you would like to give her medroxyprogesterone acetate.
Okay.
Right? How much will you give her?
We can give 10 milligram TDS, ma'am.
Okay, for 21 days?
For 10 milligram BD for 21 days we can give.
Okay, so she has to take 21 days tablet only for a bleeding for 8 days. Right? Her problem is only for 8 days and you're giving her treatment for 21 days. The problem with medroxyprogesterone acetate is the patient will have breakthrough bleeding, right? Spotting or breakthrough bleeding. So that may be an ideal drug of choice if the patient has got endometrial hyperplasia, simple hyperplasia without atypia. But in a patient who's got a normal endometrium, medroxyprogesterone acetate may not be an ideal treatment.
We can go for
if the patient is bleeding heavily, if the patient is bleeding heavily, when you see her, what will you do? Can you help in arresting the bleeding? Can you give her some medication to arrest bleeding?
The first thing will be antifibrinolytic in IV form only, ma'am. Injection Trapic I can give, ma'am.
Okay.
Then after that, if it is a acute episode of bleeding, then I can and she's anemic also, we can give conjugated equine estrogen 25 milligram 4 to 6 hourly for first.
What is the easiest drug to give, Dipansha?
Okay.
Do you have you can give her, you want to give a conjugated equine estrogen, that is Prevalence. Right, high dose of estrogen. That is one of the theoretical treatment. You can give a parenteral. We don't have it in India, but you can give a parenteral unconjugated equine estrogen. But what is the very simple, very good drug of choice?
What is the alternative, ma? What is the alternative?
Combined oral contraceptives we can give, ma'am.
Okay, you can give combined, or best would be to give her what is available. What is Primoluten?
It is a
norethistron acetate. You need to give her high dose of norethistron acetate, tapering doses, 10 milligrams 4 times a day till the bleeding stops. Then you can taper it because it has got a hemostatic activity. It helps in bleeding. The bleeding usually stops in 4 or 5 days. Try it out in your patient who comes with acute episode of bleeding. Give her tranexamic acid, give her norethistron, the bleeding will stop. So acute bleeding, norethistron, tranexamic acid. If the patient is hyperplasia, medroxyprogesterone acetate, or you can even give the patient oral contraceptive pills. She's 40 years old, right? So oral contraceptive pill in her case is not contraindicated. But if she's at a risk of hypercoagulopathy, then see pills. will be, what is the OC? What is the estrogen for OC pill that you would like to give?
35 microgram I would like to give.
Okay, ethinyl estradiol.
Ethinyl estradiol, 35.
Okay,
and levonorgestrel I can give, ma'am.
Okay, levonorgestrel. Okay, or Dynogest. You can give anything. Okay, any form of progesterone. So you usually give them estradiol or levonorgestrel combination, and you try it out. It helps in contraception, which of course this patient doesn't need, but helps in contraception and also helps in reducing the bleeding. And during the period, if the bleeding is slightly more heavy than she's expecting, then you can give a tranexamic acid.
Okay.
What are the contraindications of giving? What are the contraindications of giving oral contraceptives?
The absolute contraindications are there, ma'am. In that, any cardiovascular disease in which DVT will be there, ma'am. Ischemic heart disease will be there, ma'am. Any thromboembolic events which the patient has gone, that will be there, ma'am. Then any breast malignancy, if it is there, ma'am. Then hepatic failure is there. All these things.
Okay, so there are certain contraindications. So before you give oral contraceptive pills, irrespective of whatever dose you're giving, you need to make sure that there are no contraindications for giving oral contraceptive pills. Any other method of treatment?
Except medical method, ma'am, there are minimally invasive methods.
No, in this patient, there is a, it is called as a cafeteria approach. There are so many medications available. So you try tranexamic acid, oral contraceptive is one, or you can give a, like Dr. Shashikala already told you, given you a hint.
Marina, ma'am.
LNG-IUS.
LNG-IUCD.
How much of progesterone, levonorgestrel does it have?
It has 50 milligrams, ma'am, per day. 52, ma'am, per day. 20 microgram it will release, ma'am.
Okay. What is the rate of expulsion? What is the percentage of patients who can have an expulsion?
8%, ma'am.
Huh?
I'm not sure.
5 to 8% chance of expulsion. Okay, and this expulsion is usually seen in women who have heavy menstrual blood loss, or in patients in whom you have inserted in a type 3 fibroid, distorted uterine cavity. It's a relative contraindication. You cannot insert it. But if you insert it, there is a chance of expulsion. How many years can you keep it?
5 years.
You can keep it for 5 years. Okay. What is the added benefit of LNG-IUS?
What, ma'am?
You can move your next slides, ma'am.
Ma'am, what did you ask, ma'am?
No, I said, what is the added advantage of levonorgestrel IUS?
Added contraception, ma'am.
It is contraception. And number 2, patient does not need to take any oral tablets. How would you counsel a patient before you put an LNG-IUS?
We have to counsel, like the patient can have irregular bleeding. It can be heavy bleeding or spotting in the first 3 months, ma'am. And the patient will, 25% of the patient may go into amenorrhea in the later stage. So we need to counsel before putting only, like this can happen. And for that, we need to follow up every month, after first month and then 6 months.
Okay. And Dipansha, somewhere along the line, I heard you saying that I would like to repeat an endometrial sample. There is no role of there is no role of doing an endometrial sampling. If the patient is responding very well, then you don't have to do. It is only done in a patient in whom you're putting an IUS, LNG-IUS, for a complex hyperplasia or with atypia, which you usually do not. But in a young patient, you are doing it for a complex hyperplasia or with endometrial atypical cells, then you may have to do it. But not run-of-the-mill patients do not require a repeat endometrial sampling. If she responds, continue the treatment. If she doesn't respond, change it to some other medical form of treatment. All right. Okay. If she has got no response to treatment, LNG-IUS, she's still bleeding. Is there any other medical treatment available?
Yes, ma'am. There are androgens like Danisol is there, ma'am. Gestational.
Danisol do you give?
Danisol, is it given, ma'am?
We don't talk theory here. Okay. It is even in the books, it is given as a last line. Don't give. We don't even think about the Danisol. What is the other? Is there any role of ormeloxifene?
Ormeloxifene can be given, ma'am, 60 milligram twice.
What is that?
Ormeloxifene is a non-steroidal anti-estrogen, ma'am. It can be used as contraception as well as an AUB, ma'am. The doses are different, ma'am. In AUB, we are going to give 60 milligram twice weekly for 3 months, followed by 60 milligram once weekly for 3 months.
Okay. So this is another drug of choice in a patient who's got abnormal uterine bleeding. And this drug, there is nothing like a first drug of treatment, second drug of treatment. It all depends on what you are used to, what is your experience, and what does the. So you can use LNG-IUS even as a first line of treatment.
Okay.
There was time 20 years. Today is 20 years are over after using LNG-IUS. When we started LNG-IUS, it was not as a first line of treatment, but now LNG-IUS also can be used as a first line of treatment. Okay. What is the chance of adenomyosis responding? Her bleeding has stopped, but her pain is very, very severe. And pain is something which is very bothersome to a patient with adenomyosis, right? So what will you do? The patient has not responded to your medical treatment. Her pain is persistent. She's very uncomfortable. What would you like to do?
If she is not responding to medical management, ma'am, I can go to minimally invasive surgeries, ma'am. In minimally invasive surgeries, if, for example, it is an focal adenomyoma, I can do it like adenomyomectomy can be done, ma'am.
In a patient who is 40 years old, a regularly enlarged uterus, it's a generalized adenomyoma. It's
then
not
we
a
can do
focal
myometrial
adenomyoma.
Resection for her, ma'am. Like if it
Patients
is
usually do not respond. Adenomyosis is one of the things that
then
do not
definitive
respond to
treatment
medical
only.
treatment. So adenomyomectomy and all is a very rare situation. You like to remove the adenomyoma. Removing adenomyoma is not very easy. There is a chance of recurrence and the pain may persist. So it is done in 40 years group of women.
And she's almost 40 years.
Yeah. In this patient, if she's not responded to your medical treatment, what would you like to do?
I would like to go for definitive treatment, ma'am. Hysterectomy, I would like to do.
You would like to do a hysterectomy. Okay. Now, what type of hysterectomy would you like to do?
I will prefer vaginal hysterectomy, ma'am, over abdominal hysterectomy.
Okay.
So it will be a non-descent vaginal hysterectomy, ma'am, or we can go for TLH or LVH, both we can.
Okay. Okay. You will go for a laparoscopic hysterectomy. Okay. What about the role of removing the uterus, removing the ovaries?
Ma'am, we can preserve the ovaries, ma'am.
Okay.
We need not do bilateral salpingo oophorectomy for this case, ma'am.
What about removing the tubes?
Removing the tubes.
What is the role of prophylactic salpingectomy in patients in whom you're doing a hysterectomy?
Okay, ma'am. That will help in preventing ovarian cancer, ma'am.
And
So,
removing the tubes usually doesn't matter.
Bother about the hormone release.
Okay. What are the situations where you would like to remove the ovaries? Will you consent a patient before taking surgery for a oophorectomy?
We have to always take consent for oophorectomy.
Yeah, so you always take a consent. Okay. You don't have to remove it if it is normal. But what are the situations where you would like to remove the ovaries? It has got a follicular cyst about 3 into 4 centimeter, one ovary.
3 into 4 centimeter, we need not remove, ma'am. If it is more than
5 centimeters,
8 or 10 centimeter, we will remove.
Usually follicular cysts are not more than 5 centimeters. So is follicular cyst an indication of removing the ovary?
No, ma'am.
No. So if there is a follicular cyst, don't worry about it. Just leave it. Once the uterus is out, once the hormone, it will regress on its own. So what are the situations where you would like to do a hysterectomy with a oophorectomy, bilateral oophorectomy?
If her report would have come like endometrial pregnancy, if it would have come then.
Endometrial hyperplasia is not an indication.
The family
is not an indication for doing an oophorectomy.
If it is Lynn syndrome, like if there is a family history of Lynn syndrome, ma'am, then we need to do TH
the family history of
prophylactic
or any other indication. If there is associated endometriosis, sometimes the patient can have bilateral endometriosis, which can be asymptomatic, right? Or the patient can have endometriosis. You can just, when you see it, you know that the ovaries are involved. There is endometriosis on either ovaries. Then you've already consented a patient for a oophorectomy. So those are the situations: family history or incidental detection of endometriosis. When you're doing the surgery. Those are the situations where you would like to remove the ovaries. Okay. Dr. Sasikala?
Yes, madam.
Should take the time?
The time is over, madam.
Okay.
Any other thing, madam, regarding her presentation?
I think presentation, Dipansha, you were very confident. You presented very well. And I think she knew her subject very well. I think she would do very good in the exams. And wish you all the best. I think it was a good presentation.
Thank you, ma'am. Thank you.
Ma'am,
Okay.
there is one question.
Thank you very much. Okay. All the best. Okay. Thank you,
Madam.
Dr. Shashikala. It was nice.
Thank you, madam. Thank you.
Madam, there is a
I have
question.